All right, so I want to get started. Welcome everyone. Thank you for joining us for the Center for Learning Health System Sciences for our monthly impact seminar. It's our first one of 2023. Before we get started, I'd like to cover just a few expectations. Today's seminar will be recorded and the public slide deck will also be made available on our website under the Education tab. And I'll post the link in the chat too. Following the presentation, we invite you to raise your hand or type questions into the Q&A. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder, our next upcoming impact seminar will take place on Tuesday, March 7th with Dr. Paula Lozano of Kaiser Permanente Washington Health Research Institute. And she is the co-director of the Center for Accelerating Care Transformation. With that, I will turn it over to Dr. Genevieve Melton-Mukes to introduce our speaker.
Hi, good afternoon, everyone. I am absolutely thrilled to be able to introduce Dr. Rachel Richesson, who serves as a professor in the Department of Learning Health Systems, or Sciences, in the School of Medicine at the University of Michigan. I've known Rachel for several years now. She is nationally recognized as a leader in informatics, and in particular in clinical research informatics, and works in the space around real-world data evidence and its applications. Her research really promotes and advances the quality and usability of real-world data, including EHR data for research. And she has really, I think, remarkably put together numerous interdisciplinary research collaborations, and I'll mention a few. She currently co-leads the EHR core for the NIH Pragmatic Trials Collaboratory, and what they do is develop standards, quality metrics for clinical phenotyping using the EHR within Pragmatic Clinical Trials. She also edits the Springer's Clinical Research Informatics textbook. And then just multiple examples where she's been doing interdisciplinary work, really leveraging data. So NIH Rare Diseases Clinical Research Network, the TEDdy study, which she may talk a little bit about today, as well as really significant leadership around the CoreNet. So she is going to be talking to us about computable phenotyping in pragmatic clinical trials in learning health systems. And with that, please join me in welcoming her.
Great. Thank you so much, Genevieve. And thank you for having me. I apologize, my camera's off, but you can see my smiling face and I am smiling. And there's just I'm having a little bit of Zoom technical difficulties. So after my slides, I will share screen and reserve some time for some good discussion. So I will look forward to seeing you then. And again, I apologize that you just get slides for the next bit, but let me move on quickly to my learning objectives for this. So I'm going to talk about computable phenotyping or computable phenotypes. And before we get started, actually, I see a great turnout here. Wonder if people can put their hand up if you've heard this term, computable phenotypes, before. And a couple hands, anyone out? A few, okay, quite a few. Yeah, we give people time. Okay, so I definitely look forward to your comments in reaction to this. And I'll go ahead and use the hand raise feature a few more times throughout just to sort of get a sense of where people stand. So I will talk about computable phenotypes for those that aren't familiar with the term. And I'm going to really focus on ways to find them and assess them for different research uses and discuss the importance of reporting phenotype definition features and how that relates to our common vision of learning health systems. So I will speak largely from my experience with the NIH Pragmatic Trials Collaboratory in my EHR experience. I will define computable phenotypes and again, talk about really strategies for finding and assessing them, which is a challenge. And then I hope we can all have discussion about future and implications. So first, let me define and share a couple words about embedded pragmatic clinical trials, which are those that are, as you might guess, embedded within healthcare or real health delivery systems. And there's a number of benefits for these. This design and the interest in pragmatic clinical trials has evolved in response to this need for generalizability of studies and to reduce the costs of clinical research, which is substantive and not sustainable to answer all the questions we need. And one defining characteristic of pragmatic clinical trials is the use of existing data streams. So to be pragmatic and not take the time and resources required to set up new data collection stores, but rather to reuse what we have. And largely, this is through existing EHR systems. So that is the aspect I'm going to focus on a bit. The Pragmatic Trials Collaboratory is in its 10th year. It just celebrated its 10th anniversary. And I was lucky enough to have started at Duke when this was starting up, the coordinating center of this. And this is a project funded by the NIH Common Fund, but then individual demonstration projects are funded by individual NIH institutes and centers. So it's very collaborative, far-reaching impact in the collaboratory with the goal to strengthen the national capacity to implement cost-effective, large-scale research studies that engage health delivery organizations and as research partners. So effectively pragmatic trials. And the way NIH funds this is through a number of demonstration projects, and we've had 22 projects over the years. Some have completed and some are ongoing, and they range from everything from colorectal cancer screening to palliative care interventions in the ED to buprenorphine administration in the ED to nursing home advanced directives to infectious disease precautions in hospital. And we've funded quite a number of HEAL studies, which are the NIH opioid reduction research and alternative pain strategies. So we're looking at things from acupuncture to physical therapy now, and just a number of different settings, populations, clinical areas. And so through these varied demonstration projects, the NIH grows their capacity to understand, what methods work and how we can learn from them. So all these projects have a one-year planning phase, and then they move into their trial. And all these programs are supported by cores. So Duke is the coordinating center for the NIH Pragmatic Trials Collaboratory and supports a number of cores that contain that represent members of the different demonstration projects and other experts in these areas. So there's the more virtual cores, they're not centralized in North Carolina. And so we've got quite a few of them. I co-lead the EHR core, which years ago was called the Phenotyping core. And now we've expanded our name a bit, and we really include all things sort of informatics and EHR related in our chart. So I'm going to speak from that experience. And one thing we found, so on the left of all our different trials, virtually all of our trials are using the EHR for eligibility determination on the left. So the gray area is how they're using EHRs in their study. And then a good number are using them to actually deliver the intervention. So in terms of structured order sets or reminders or other kinds of practice alerts. And then nearly all of our studies use EHRs for the outcome assessment. So instead of having a new data collection, they're using existing measures from the EHR. So those are the three broad areas that we see EHRs used. And there's a lot of trials that have a lot of cumulative experience in that. We've learned a few lessons, which I based on the seminars that I know you've had in the past. So you've heard David Dorr and Tom Campion talk, right? Some of the challenges, but no EHRs are alike. I think Tom Campion said in his previous lecture, you've seen one EHR, you've seen one Epic EHR, you've seen one Epic EHR. So people can still customize which codes they're using, how they're using. And we found in all our studies that are multi-site, you look at the data and every single project has reported that there's challenges across sites on how the data is coded. They need methods to standardize or building reference models, mapping to a common standard, getting involved with people at the local sites that understand the data. And sort of the take home is more sites, more work. It's a lot of work at each site, even if they are using the same implementation. And in addition to data variation, there's also just functionality differences. So our trial on suicide prevention was using some of the Epic registry in reporting workbench functions, and found that their different sites used them differently, and they really had to do this local adaptation. And this required IT resources and time. And then finally, again, no surprise, I think, to anybody that works in healthcare and looking to use those data from the EHR, it's really optimized for billing. So the standardized elements that we have are the required billing coding systems. And if people want to change that or add even one more data element to that, or use a piece of data for research that was not necessarily intended to do so, there are a lot of challenges with that. And so our investigators all have hard lessons learned and are trying to come up with strategies to help people overcome the fact that the EHR really isn't designed at this time to support research or many of the other functions that we are looking for learning health sciences. So collectively, this research, our EHR core has written a number of papers that I'll just direct you to if you want more information on the specific studies. But through these, we have come up with a number of general recommendations that I think are really useful. One is to engage systems as research partners to get that access to the local IT staff that's really needed to understand the data and begin to use it for other purposes. Frequent communication among staff and research teams is critical. Systematic data quality tests are required throughout, and that this requires planning and time and staff. So even if you're working on projects within one health system, the periodic data quality checking is a big deal and something that you really need to plan ahead for, and I guess just plan in terms of money and time and possible frustrations. And then final recommendations this is sort of our charge for the next 10 years, or to think of how can we begin to augment our EHR systems with additional data collection, and how can we sort of coalesce on standards or encourage the use of standards as we do this. So we encourage using elements from a standard library. So the example you saw of the sort of the REDCap community coming together to leverage REDCap for various types of research. I've seen groups coming together to try and standardize elements. Can we then begin to promote some of these elements actually being included in the EHRs through legislation or just within different research networks? And finally, can we share our computable phenotype definitions, which is one of the take homes I hope you'll have today after this talk. So I've gotten this far without defining computable phenotypes, so I think we'll do that soon for those that aren't familiar. So phenotypes are specifications for identifying patients or populations with a given characteristic or condition of interest using data that are routinely collected in EHR. So my shorthand for this is usually just an EHR-based condition definition. And as I showed, this supports many phases of the research, from screening and eligibility determination to actual outcomes assessment. So here's an example of a computable phenotype. This is a rule-based phenotype. I mean, we are moving into a different world where people are doing more data-driven types of things, but generally and historically how they've worked is groups of experts come together and sort of conceptually identify a condition and what types of data would be needed. So in this case, we've got a reference to, I've got my little call out bubbles here, to various ICD-9 codes, and there's a list there, various lab codes or medication codes that can be pre-specified. But there's also a little bit of logic to each of these. Not always terribly complex, but needs to be represented if you're thinking about reusing one or trying to implement something in your organization. The people doing the data pulls need to be very clear about how this logic works. So here we have any combination of two of the following events within 24 months. And so this is the kind of stuff that you see, the logic as well as the specific codes in a computable phenotype definition. And so there's a lot of potential for variation, but if we think about how these computable phenotypes in a research context are ultimately generating results that will be shared. So imagine a table 1, and you're reading a study, you're reviewing a study, and you see these features about patients, whether they were selected on or this is sort of their cohort characteristics. You can see there's all kinds of reference to different clinical conditions, and the information on how that was assessed actually and operationally in sites, especially in a multi-site trial, trial is often missing. And so there actually could be multiple ways that one could assess diabetes. And this is just an example. I've written a few papers, and there have been several papers since that have looked at all the different phenotype definitions that are available for diabetes. I mean, upwards of 80 different variations that have been seen published. And so how is one to know what works and what was used in terms of being able to identify and evaluate the study based on the similarity to patients that like yours? So there's a number of benefits to sharing and reusing phenotype definitions. So again, think back of just that logic, the list of codes, the logic that goes with them. How was this cohort of patients identified for a particular study or inquiry? And so the ability to share those has immediate efficiencies just in terms of startup of new studies, but just being able to compare different data sets or studies to be able to report results, and then through either journals or through data reporting requirements on clinicaltrials.gov or NIH, this kind of information could be very, very helpful for future users. And if we could reuse that, it could save all of our time in complying with these requirements. So again, we're here, we're all passionate about creating learning health systems. And so this is just my favorite slide of learning health systems of all times, for the internal and the external. And so, research influences practice and practice influences research. And if this is the case, and if this is one of our models, then it certainly seems reasonable and ideal for us to have the same condition definition, so that in many cases, we can use the same phenotype definition. We can access it from the research that's published, then look at it, apply those interventions if they're shown to be effective in our populations, and learn more and report back. And so I'd like to offer that standardization and explicit documentation of our phenotype definitions can really support us in this mission. So if you think about reuse, I'll use this to guide the last part of my talk. There's a number of steps involved. First, you have to find a phenotype definition. You have to assess if it worked for you. Then you implement it. There's some validation. Then you report your results, and you're publishing your results. And so I'm going to sort of go down these linearly. And there's challenges at every turn, as you can imagine, and is typically the case with, with research and health research. So first, where can you find phenotype definitions? The first logical place that I've seen, and I often go to, is the CMS Chronic Conditions Data Warehouse, which has been developing methods and shared definitions to support claims-based research for a number of years. And so this is, they focus mostly on chronic conditions, but it's a good first stop. And we'll have the kinds of codes that are typically found in EHR systems. I mean, at least your ICD based codes there. So that is a good place to start. But moving beyond and also thinking about more clinical data. Oh, this is an example of one from the CMS. So they'll give you, the name of the condition, update date, and then list of codes, and then some of the important logic here, whether it's an inpatient stay or skilled nursing facility, and how many claims within a certain time period. So it gives you a little sense of what that looks like. But then if you still wanted to move on beyond that and move into other data types, including some natural language or text analysis, where do you go? The sort of the vanguard phenotypers and effort is that I'm aware of is the PhKB, and I'm curious if folks on the line, if some people could raise hands if they have heard of PhKB before. I've got at least one. Oh, hi, Steve. Let's see, anyone else? Sometimes a lot of people have heard of this, a few, okay, but never a majority in an audience. And I think part of that is because this is sort of a niche research area. The PhKB evolved from the eMERGE network that was working on GWAS and PWAS studies. And so that collaborative expertise came together to develop standard EHR conditions to combine with work and data from biorepositories. And so they had sort of mature EHRs, a good collaboration, and and there's some great work here, which I'll show, but I think outside of those communities, there's less traction, and there's not, the content is not exhaustive in here. So until something becomes useful and has what you need, or until we have incentives to help people get stuff in there, it could be a challenge. So that might explain it. But this is, to my knowledge, the only dedicated phenotype knowledge base that we have right now in the US, and is also a great first stop. So if you go to PKB and you look under phenotypes, you can look by different conditions. There's maybe 100 definitions that are posted publicly. Actually, it's probably a bit less than that. There's also a private collaborative space. There's all kinds of tools here. And then you could get a quick overview of who created the phenotype definition, the attributes and codes that are there, and the status, and then some typology here. But it's sort of some searchable metadata, but not a ton. But I encourage people to go there. And you also see, I see ICD-10 and 9 codes here. There's a lot of older definitions that just have ICD-9 codes that haven't upgraded to ICD-10. So again, it's just has limited use in that way, because it just hasn't been heavily invested in. It's maintained, but that might explain why some folks hadn't heard of that. But then if you dig further in PKB, then you could get to the data dictionaries. I see some estimates for positive predictive value here in metrics, but there's not a lot of data on the populations and the prevalence of the populations of which those numbers were generated and reported. CSV files, occasionally you see some Word docs here, but anyway, they're stuck, right? So if you see phenotype definitions, there you can dig further, get the information, and track to someone who's used it. So it's to me, a great illustration of the kinds of things that people need and people want to know if they're going to reuse phenotype and build on all those efficiencies that I mentioned, but it still takes time to sift through, and we really don't have a terrific platform that's going to have everything that everyone needs in a very usable way. One new platform that is very encouraging and exciting is the Health Data Research Alliance phenotype library. So this is out of the UK. It's from their UK National Phenomics Research Project. And they've put up a phenotype library recently, and there's almost 800 phenotypes on there, lots of concepts, lots of codes. I'll just give you a peek of the usability of their interface. So just searching under Alzheimer's and related dementias, I guess I searched under dementia here, just to give you an example. There's a few, there's I think more than 20 came back. We've got sort of the type, the collection coding system, the data source, date, and authorship are there. If you dig a little further and pull up one, again, you can see there's a unique identifier and a version, because you can imagine these things change, they get updated, we need some versioning. Gives a little more specifics on the data types that it's looking for. It's got a definition, some links to implementation, and then down below publication. So that's sort of a new feature, but really important, right? You want to be able to, you see a phenotype definition in the literature, you want to be able to link somewhere to find those details. And if you see a phenotype in a phenotype library, it would be great to point to a publication that could tell you more about how that was used and if there was any validation and what the results or the impact of that was. So this is, of course, I haven't used it myself much other than just stumble on it, but I think it's really underscoring how important this kind of tool is. And I hope these resources will continue to improve and support us in our work in the future. The Odyssey network is the Observational Health Data Sciences and Informatics. So I'll also do a quick show of hands. I'm curious how many people are aware of that or involved in that. Dylan, Steve, I figured you would be. Yeah, okay, so good. So a few, but again, not everyone. This is a very exciting group. I think it's been mentioned in your seminar series before. This is a group that's built in maintaining the OMOP common data model, where health systems can map their data to that model, and then through the Odyssey network, people could do distributed queries. And this is largely developed to look at drug safety and surveillance problems and types of questions, but it's a really exciting grassroots kind of community, lots of tools, and a very spirit of openness and sharing. So they have a phenotype library. And if you can see this small print, it basically says coming soon. And it has been coming soon for quite a while. And I think that just underscores the challenges that are there. No doubt, there's a lot of phenotypes that are useful that you can't find on a platform like this, but you can find them in GitHub, or you can find them on the web. But having a searchable platform for them is really difficult because one has to start thinking about what are the things that people want to search on and what information do people need. So this is an exciting community to watch. Lots of tools, probably lots of ideas and code that you could even use for phenotypes. But you have to hunt around a little. One thing I found that I want to just walk through briefly is this blog on Phenotype February, which is actually, this group started this last year in February, and they're doing it right now, and looking at a handful of conditions over the course of a month. Last year, they did all 28 days, 28 conditions, and describe each one. This year, it's a little more work. They're doing a few less conditions and they're digging deeper. But I just, again, to continue my example with Alzheimer's and related dementias, on February 5th of 2022, that was the highlight of a Phenotype February. And so Patrick Ryan, who is he's at Janssen and assistant professor at Columbia, has done quite a lot of work in building the infrastructure of Odyssey, and his background is in biostatistics. And so he explains his experience, and I encourage you to follow that link or search on Phenotype February, Alzheimer's disease, or any of your conditions. It's really interesting journey. So the first part of his journey was, how do I even see if there's any existing phenotypes out there? So there's not a mesh term for phenotype definitions. So first you look for your condition and then the type of study. I know we did so much of this in our collaboratory in the early days, and in PCORNet, in the early days of PCORNet, trying to find what was already there. You'd search registry, epidemiology study, different types of studies. And this was just an example of his keywords, but they're hard to find. And then he did find a number of studies and found this. So you don't need to be able to read the detail. I know it's very fuzzy, but the idea is that he found the CCW, the Chronic Conditions Warehouse, has a definition. There's a list of codes and some of their logic. He pulled up a study by Bynum here from UMich, actually, and then another one where someone sort of edited or augmented her list of diagnoses for Alzheimer's and related dementias, and then they've got slightly different logic, and so those are published, and then that information is in a table published. He found yet another study that sort of put it in a table that was like an image file of a table, so not even something that you could sort of scrape easily, but it listed the ICD-9 codes and the 10 codes. But if you dig in the literature, in the discussion of the study, there's even a little more nuance and detail about what was actually done to develop this and apply it. So again, just variation. So, he came to this question, which is a question that we all have. So you've got a condition, you're trying to identify a phenotype definition to reuse. You see several, there are different code list formats, there's different lists of codes. And the big question is, what are the differences between the different phenotype definitions, and are they impactful? Do they make a difference in what you're trying to do? And so the Odyssey network has its set of tools and approach, which is to use a reference set of concepts for a reference terminology called SNOMED-CT and sort of map things to that, but they do a lot of iteration and a lot of testing with data. And so interesting approach and lots of shared tools. So if people are interested, it's definitely worth digging around on. But really, in summary, I just tell all these stories to let you know it's not easy to find phenotype definitions, but you should try. It's worth it, and I think a number of us are trying to work to build and grow these kinds of platforms. So hopefully the resources will continue. Certainly look at published literature, existing research networks, especially like disease-specific networks, and then the CMS resources, as I mentioned. The National Library of Medicine has a Value Set Authority Center, which lists value sets using quality measures. So that's a source. GitHub, you can source. And then I consider Odyssey an advanced and enhanced code repository because they have many of those tools. And then some of the actual proper phenotype repositories. So that's where I would go, and it's still a little bit of work, but I think it's worth it, especially if you assess it and find that you could save all that time building it and potentially to have some shortcuts in validating it. There's still an open question about how much one needs to validate when porting things around. But anyway, so you find a phenotype definition, and then the question is, how do you assess that, and how do you decide if you really need to build something? And so I always like to highlight this great thesis that Blake Cameron did. He's a nephrologist at Duke. He did this for his master's thesis at Oregon Health Sciences University. And he basically described sort of what makes a good phenotype and then what kinds of review criteria are needed. So this is very readable, and it's a few years old, but I think very accurate. So I'd encourage you to search on User's Guide to Computable Phenotypes if you want more information. But he basically laid out his criteria in a few ways. There's sort of overall questions like who, what, where, when, why. What is the purpose for which it was developed, really? That's what you want to know. And then you want to know, is this valid in my patient population for my intended purpose? And to answer that question, you really need sort of someone with clinical expertise or clinical research expertise. And then there's a whole set of questions about reviewing it that are just more technical, and you need an informatics or a data analyst, a more technical person to actually say, can we do this? Do we have the right data? Is the documentation complete? And does this match with the information that's available in our system? So I think it's really interesting. Just this highlights to me, that there's multiple players involved, like with everything. Like team science is just, it takes so many people. So very readable summary there by Blake. And then I also want to talk about more recently, we've got sort of the same ideas. So Laura Wiley is assistant professor at UC Denver, and she's really focused on phenotyping, algorithms, and validation. And she's also looking closely at the nature of different definitions and whether or not they are at risk of promoting bias or building biased populations inadvertently due to the types of codes that are selected and how that relates to how care is delivered. So she's actually got a lot of work in progress that's at preprint stage right now, but under peer review, where she's done exhaustive literature reviews, first of all what's published, just to determine that, yeah, people aren't posting these the details that one needs to replicate a phenotype definition are generally not being reported. And it's really hard to be able to capture that information that you need. She boils it down after all her experience of really delving in this field. She always comes down to these two questions, which are, does this definition capture the right patients for your intended use? And does it have the right performance metrics? So it sort of speaks to what was the purpose, what was the design, and then how well does it perform? And those are our really big questions. So let's talk just a moment more about assessing. Those are the big questions, I think, that Laura and Blake have brought forward. But all the purpose, and then we still get back to these metrics. So sensitivity, specificity, and PPV. Gold standards to review these, and it takes time and money. So there's trade-offs in terms of the pragmatics of doing these kinds of assessments versus the integrity of the data and the study you're trying to build. So then the next phase is implementation. And again, just to summarize, to do that, to re-implement, do you have the clear documentation? Do you have the required data? And is it formatted correctly? And do you have the capability? So those are the kinds of questions that are asked. And then validation is really important. And I'll just gloss over without going too in detail. This is a challenge. There's many options. I think that PPV is what we often see reported the most. Sensitivity and specificity are really important metrics, but those require gold standards and take work and time to do. So you'll see a variety of metrics reported, but it still comes back down to our 2x2 tables here for that are built on the screening test. So also, I just want to mention that if you are going to compute the sensitivity and specificity and other performance metrics, there's actually quite a process. And again, it's not critical to read all the boxes here. This was developed by Shelley Rusinkovich at Duke at the start of the CoreNet in a lot of work when people started looking at phenotypes. But basically, the blue describes the informatics or the statistics activities, and the green highlight the clinician. So there has to be a database of the different to collect this gold standard chart review, and there have to be experts that have the criteria for this, multiple experts, a standardization process there. And there's a database that needs to be developed, and then you sort of collect your data based on your expert reviews and analyze it to compute these statistics. So there's a protocol and some rigor that's required in doing a validation, which can take time and resources. So the types of validation, I was just describing a gold standard validation where you have somebody manually reviewing patient records to find truth. And there's many ways to go about defining who is manually reviewing and how many people in the adjudication process and all that. To ease that burden, some people have used comparative gold standards. If you have an option to derive labels from another source, like if you have a registry parallel or a patient reported outcome or another measure that you could use instead to sort of validate your classification of somebody with a condition, that's great. And then there's a lot of research, which is not my area, about doing sort of probabilistic models and really looking at data and other elements to try and predict whether someone has a condition or not. This paper also highlights some, sort of summarizes what I said in terms of factors and options for validating phenotype definitions. At the end, I'll give a little shout out to this article by Martin Chapman, and really all the phenotyping experts that I know of are on this. So this really represents a pretty good consensus, but there's a number of ways to think about validating phenotypes. And so there is some literature out there to guide you, but it seems to be important, at least on some level, any reuse to have this validation for your particular purpose and your particular setting. But there can be options that perhaps are more pragmatic, and you can look into those. Data quality, the quality of the underlying data absolutely affects the results of your phenotype-based queries or your computable phenotypes, and that you just need to be aware. I think people are in this group that healthcare data are not necessarily collected for research, and that a data quality assessment should accompany a phenotype validation. So if you've got lots and lots of missing data, for example, that's going to affect the performance of your phenotype. And so these kinds of assessment metrics would be helpful to come with your phenotype validation. And so a number of us in the collaboratory are promoting those kinds of ideas, as well as the idea that a workflow assessment should be included if you're doing multi-site studies. And again, you're not meant to read this, but just think of a workflow diagram, understanding where codes are applied and in which settings would have the opportunity to enter certain kinds of data or to preferentially use different codes is really important, and especially on multi-site trials. Data quality, there's lots of dimensions, but completeness, accuracy, and consistency are sort of the big ones, the big three, and there's a number of examples for each of these. So there's multiple metrics and approaches to looking at completeness or accuracy, which is the hardest one. That's our, how close to truth are we, or consistency. So there's a growing body of literature on that, but it's important to really have, I think, a data quality eye as you're thinking about phenotypes and any EHR-based research. So now I know we're getting kind of towards the end, and we want to have some discussion. So let me sort of quickly talk about the next few phases, which is reporting and publishing. So again, as you're reporting research, if you are using a computable phenotype, when you're reporting that, to be able to share the purpose and the context that you develop this in, what are your specifications so that others can reuse or at least understand your research, and then specifically the idea of however you choose to validate it, that information is shared, and any experience you have, it would be great that we could build communities that we could share that kind of information. And so there's informal channels, but not some single platform to do that now. So it's an interesting time to see. As we think about reusing at scale, I think we need to think about platforms. Like I showed some examples, right? But none of them were perfect or had all the coverage we need. So, identifying those and growing those would be great, and even locally within your organization. So at UNISH, we're looking into how can we support the reuse of phenotypes in our group, and I hope you are as well. And there's just obvious efficiencies that can be shared there, but it's hard to do, and it takes resources, and we need to motivate people. So This is the article I mentioned by Martin Chapman and others. If you're interested in developing an EHR phenotype library, someone has already made the specifications and the requirements for you. And there's a lot of technical ones about how they should be modeled and logged and the information that you need to implement them. But I want to point out on the right, top right, sort of the blue areas about validation, this desiderata really points out that we somehow, if we're sharing definitions, need to think about how we can support a defined validation process and enable some of this to happen. And Odyssey is doing this kind of thing within its network, but we could certainly think of how we can grow that into different types of settings. And this ability to enable feedback as people apply and reuse, I think would be wonderful. And I just want to highlight, I pulled this from your website, which I think is, which I guess you pulled from IOM, but again, if we think about LHS, there's leadership, culture, and incentives, right? How do we build a culture that makes it easier to find and reuse? And how do we incentivize people to share their definitions and to reuse others so that we could sort of move to reduce this variation of computable phenotypes that we're seeing? So I think the LHS lens is really appropriate for this. And then I'll just wrap up with a couple highlights of the future. Things are incredibly unstandardized now, and that's why we have this whole situation of needing common data models, which I don't know how much you've covered here, but there's a number of common data models to get over it. But now we've got something called FHIR that's coming along, and people are, crazy excited about it. But there's potential that we're moving towards some set of data elements that may be more standardized in EHRs moving forward, and ultimately make this easier. So that's an exciting development with lots of excitement around it. We're just seeing increasing levels of information sharing outside of traditional health systems, and people are thinking thinking harder and implementing standards to support data across different care settings and over the life course. And so I think that offers us a lot of opportunities to learn. And then in this area of computable phenotypes, the FDA is incredibly motivated in bringing forth a lot of guidance every few months about how can we use real world data to support choices and to learn. And in their case, they're looking very specifically at safety and advancing their ability to make decisions faster on new products. So that's exciting. And they pointed out, which is exciting to me, that computable definitions, like they should be described in the protocol, they should be available in a computer processable format. So I think this will stimulate tools and development in this area. And with all that said, it's exciting. We're getting data standards. We're getting really use cases that say, hey, we need this data to be more usable for quality measurement, quality improvement, research, public health, all these things. So it seems like an exciting time that we could be a part of, primary users in a way. All these uses were always called secondary EHR uses, but moving forward, maybe these are the important use cases, and we're getting standards in, and we're getting more data, more useful data potentially in the EHRs. But so that's an exciting paradigm shift that we could leverage EHRs for more than billing. But I think we all need to be cognizant of, and I know everybody on the call is about the importance of the care team well-being and provider burnout, which are very real dynamics. And so adding more research data to the EHR isn't the answer. It's harmonizing and reducing the elements we have, building multi-purpose elements. And to some extent, I wonder if the computable phenotype standards of how to use code systems consistently and efficiently might sort of in some way feed into helping address some of these problems of documentation burden. But at any rate, it's a big research and learning health systems functions are one part of a big ecosystem, and the providers putting in the data definitely have to be considered in that. So to end, I'll just point you, if this is interesting about this approach of using EHR data in pragmatic research, we have through the NIH Pragmatic Trials Collaboratory, we have a wonderful online text that's fairly updated that talks about all aspects of pragmatic trials, but I'll highlight here the EHR, let's see, we've got electronic health records-based phenotyping, and also just the use of EHR data in pragmatic clinical trials. And they're very readable summaries, and they point with lots of examples of our studies. So I think those are terrific resources. And with that, I'll thank you. And I left a few minutes for discussion, not as many as I wanted to, but I'll stop sharing and share my video and see if I lost people. I think I lost a few.
No, thank you, Dr. Richard. We do have several minutes left for Q&A. So if there are questions or comments, if you could raise your hand and I'll unmute you to ask verbally, or if you want to type them into the Q&A, that's an option as well.
I hope, while people are thinking of questions, I guess I would love people's thoughts on sort of additional data elements. The phenotype definitions that I'm familiar with are all built on the standard code systems that are used, so the ICD codes, PCT codes, medication codes, and lab codes in LOINC, although there's not every system has that capability, but there's sort of those big areas. But we're finding in the Pragmatic Trials Collaboratory that that's not always enough information for any particular study. So I think, approaches to getting standardized data, looking at standards to inspire research data collection items or sharing those. I wonder if people are doing that, or if that's of interest to this group. I hope I've at least given you a motivation to look outward. I think we all need to be standards developers and promoters.
Certainly. Yes, Mary raised her hand first. Mary.
Oh, I see hands up. Oh, good. Yeah.
And I will make this short, and we can always table it if there are more on target, because my interest is as a evidence synthesis systematic reviewer. How do we assess this and think about it in terms of the strength of the confidence that we can have in the findings that are based on these things? And I'm thinking about how we might need to update potentials for risk of bias when we're thinking about evaluating a pragmatic trial and its ability to contribute to our understanding. So I'm just wondering if that, I'm seeing the validation and all the other material you have there. If you are aware if thought has gone into that end of this spectrum.
Yeah, that's a really great question. I don't know. I think there's interest, and I would imagine that systematic reviewers would absolutely benefit from this explicit definition. The validation approach, yes, but also just being able to compare study A versus study B. Looking at the definitions, could one say, oh, these are very broad and could have a lot of false positives, for example. Not everyone with this code has this condition. And I wonder if there's been any work about sort of using that information to sort of weigh studies in the sample or something. Would you say it's frustrating or difficult to pool or try and compare results from studies without this kind of information? I'm wondering if you felt, that maybe things were underspecified.
Yes, most usually underspecified. And so what you're raising for me is an interesting question in terms of thinking about this with regard to the applicability of the studies and maybe having a little better sense of precision and nuance when it comes to thinking about to whom we should be applying this information to. But that's it. Thank you. I will get out of the way so you can have more.
Yeah, no, I guess it's funny. You're seeing things from the perspective that I am not, and maybe in 10 years we could help, because I think what we're trying to do in the Pragmatic Trials Collaboratory is sort of say there's standard reporting for a pragmatic trial. So like the consort statement, and I can't remember what the status is, but the collaboratory has proposed, like, these are the things that should be stated clearly about defining the population. There's a note about phenotypes in there, and there's a note about the data quality assessment, but it's a broader reporting criteria to share with journals. And I think that's getting out there. And as people start reporting that, then I think you might see more in your community about how do we pull this together to make those kinds of choices. So it's exciting potential. Thanks for raising that.
Yes, and Mike Usher was the next person to raise his hand. Mike, do you still have a question or comment? Okay, while he's considering, in the Q&A, there is a question from Steve Johnson. Thank you for your excellent overview of phenotyping and current issues. In practice, researchers seem to always create their phenotypes from scratch. As you point out, this is because it is hard to find phenotypes, and then it is impossible to know if it meets your research needs, i.e., is it sensitive or specific enough for my study question? How do we encourage more actual reuse? Are there groups who are doing reuse well that we should emulate?
That's a great question. And I think that's sort of my research area. So I haven't seen any. I think it would be really interesting to do. And so we have one grant in development. Laura Wiley is leading this. She's the one from UC, but she's and a number of CTSA sites are sort of exploring the idea of, if we offer these tools, can we measure uptake? Can we just measure that, a library has an impact? Or, in our case here, we're working with education component. Are there modules that we can use to encourage people to reuse, show them the benefits, show them the value, make it easy, and then sort of see which of those messages work and if they have an impact. So I think this is really new area. I think it's harder to reuse. I wish I could think of a funny quote. We do this with, there's a lot of standards quotes, but everyone thinks standards are great, or like toothbrushes. You think it's great, but you like your own. And so it's just sometimes just easier to do your own thing than to do what it takes to reuse, collaborate, right? It takes more to have more people involved. So I think those barriers have been so huge, people haven't thought as much about it. So yeah, that's my interest. And I have my email up. I would certainly love to talk or work with people further to think more about that. Great question.
Okay, next we'll go to a question that's in the chat, actually, from Dylan Crimes. Question on the analysis squares slide, which was just before the flow chart of the phenotype evaluation process.
Yeah, okay, I'm going to do it and hope, and hopefully I won't crash. I have such an unpredictable relationship with Zoom. Are you seeing the slide? Is this the slide?
Yes, that's the slide. And so the question is, like, regression is common for analysis of phenotype and machine learning to establish a phenotype. I'm not sure if that's, Dylan, did we ask your question, or would you like to verbally ask your question? Oops, I think, oh, Rachel, are you there?
I'm back. I'm going to share again. I should have turned off my camera. This happens just enough to be irritating, but then I get a false sense of security with my Zoom when it goes well. Let me throw that, and then if Dylan could ask the question again. I think this was the slide, right?
I think the question is, to validate a phenotype, is regression.
Yeah, where was I? Yeah, the regression stuff, I think I'll stop. The machine learning, the idea of sort of looking at the data, clustering, identifying what the condition is from there.
You can hear me though, right, Lindsay?
Yes, I can hear you.
Yeah, it was just about using the formula that's in the square for an established phenotype to validate it. That was really what I was trying to type in, but because I'm kind of curious about that, because I work with EHRs myself.
Yes, I'm unsure if
oh, I'm sorry. Yeah, I didn't turn on my mic. Okay, so sorry, Dylan. Okay. My screen sharing's up. Yeah, I think that the idea of, no matter how you develop your phenotype, having a gold standard, then you could use that basic 2x2 table, which I'll share the slides, but those are everywhere. If you just, it's the same as.
Yeah, I've seen that before. I was just curious whether or not it's machine learning or stuff that's, I haven't done any analysis on phenotypes. That's where I'm coming from.
Oh, okay. Yeah, what I'm showing is definitely not machine learning. It's just a very predetermined, pre-specified. You have a condition definition, and you have a gold standard of,
Okay.
you know, and you compare them. Now, your condition definition could have been something that was derived from machine learning or some other data-driven approach, but then if you were going to do a validation step to that, you would say, well, what's my gold standard?
I see. How many
analysis.
records, like when you have an established phenotype to do this validation metrics, how many kind of records do you need? Or can I ask that kind of question, I guess?
Yeah, it depends. It depends, and it's interesting. Somebody threw this out me. It depends on your condition and what level that you want. For sort of like 100 to 200 is sort of what I see people doing.
Okay,
for a thorough one. But cool. Then in other talks, people have suggested, you know, is there something more pragmatic that can be done? I think it's a sort of an open question on what's the ideal number, and are there ways to reduce that?
Perfect. Thank you.
Yeah, thanks for the question. Sorry for my screen challenges.
No worries at all. A question from Dr. Milton Mukes, wondering your thoughts about computable phenotypes that are AI or ML enabled that are potentially black box and lack explainability. How acceptable will these be?
Yeah, that's interesting. That's a really good question. And I'm not in the camp that's developing all those, but I'm nervous about taking I think we can use the machine learning and a lot of these techniques to identify important clusters and identify associations, but you know, if we're going to be applying the evidence to people, then I think we need a more clear definition, and we need to understand what that is. And in terms of research, I know there's a lot of people doing a lot of sophisticated things with data and identifying groups and disease subtypes, and there's definitely a camp of people that say forget all the rule-based stuff. But it feels, I don't see that going away. I mean, it just feels like what people, clinicians and researchers are comfortable with, saying these are the kinds of patients we have, and we know they look like this, and start with that, and then sort of move on. So I'll say, I think it's still to be determined what is going to be the role of machine learning in all this, and what levels of validation are required. But I think the black box is a challenge, and we need to find ways to address that. People are working, as you know, on tools to sort of enhance explainability. And I think the worlds need to come together, but right now there's sort of two different worlds in phenotyping, and they're very silent at this point.
Okay, there are two questions remaining. Do you want to answer them live on the recording, or should I follow up with you afterwards?
I think you'll have to follow up because I'm not seeing them anymore. In my, under the Q&A, yeah, I'm not, answer dismissed. Yeah, I think I'll just follow up afterwards, and okay. That's probably easier because we're right at time. And I'm sorry, everyone. Thank you for the great discussion. I'm sorry I didn't leave enough time for discussion, but hopefully you've enjoyed this. I certainly have.
Yes, thank you very much for your talk today and answering those questions. And thank you everyone for attending. We'll resume March 7th with our next impact seminar. So this concludes our presentation. Thank you, everyone.
Thanks.
Have a
Bye,
great day.
everyone.
Thank you.